Hello and welcome to Let's Talk Health and Care, the podcast where we explore the latest innovations and important topics in health and care. I'm Peter Brindle. I'm a GP with a real passion for service improvement, health tech and innovation.
And I'm Mark Griffiths, Pro Vice Chancellor and sponsor for the Integrated Care Academy at UWE Bristol. Welcome to Let's Talk Health and Care.
Today we have a very special episode. We're diving into the Inclusive Training Within Practice project. It's a fantastic initiative aimed at improving inclusivity in healthcare education and in practice. And we are very pleased to have with us today Noor Nixon, the project manager, and Antony Hill, the principal investigator. Welcome to you both, Noor and Antony.
Thanks, great to be here.
Thank you.
So let's start with some broader introductions. Noor, could you just tell us a bit about yourself and your role in this important project?
Yes, absolutely. I'm Noor. I'm the Inclusive Practice Project Manager here at the University of the West of England, Bristol, and I oversee the development and implementation of this project, the Inclusive Training Within Practice project, and my main role is ensuring that we meet our goals and deliver impactful resources.
And how about you, Antony?
So I'm Antony Hill. I'm the Dean of Learning and Teaching for the College of Health Science and Society at UWE Bristol. I'm the principal investigator for the project and I work closely with Notified Leadership and Oversight.
That's great. Now, Noor, let's get going with this. Could you give us a summary of a bit about what the basis behind the Inclusive Training Within Practice project was all about, why you did it, and importantly, what did you actually do?
Great, thank you. So this project is a continuation of the previous Health Education England funded project, which was to look at the Black, Asian and minority ethnic student support in practice. And the project incorporates insights from research projects from other universities, such as the Bournemouth University Research Project on student experience during placement. We've also incorporated the findings from the BRAP Too Hot to Handle report. So we've really looked at insights and learning from previous research and findings. So this project is a 15-month multi-system, multidisciplinary initiative. It's funded by NHS England South West and, as I mentioned, led by UWE Bristol. And of course, this is part of the Integrated Care Academy led by UWE. Our primary goal is really to improve the experiences and outcomes of Black, Asian and minority ethnic learners on healthcare programmes, but we also include improving the experiences of international staff in healthcare. We are doing this by providing a range of learning resources designed to address racism and discrimination, and we're aiming for systemic change in culture and behaviour.
So what sort of changes do you think could and should be made on the back of these resources? Now, I know this whole area is pretty sensitive and very important, but I don't think we should shy away from perhaps hearing about some of the really important and unfortunate experiences that people might have had that have perhaps driven you guys to doing this work in the first place.
Yeah, absolutely. I mean, we hear about published data, such as the Workforce Race Equality Standards. We hear about the ethnicity awarding gaps, but actually the real lived experience is what we're looking at. And I can give you some examples of these behaviours from the workforce that have been shared with us by the minority ethnic students and staff. So examples would be microaggressions, very much so. What that means, for example, is where staff are not using names or pronouncing names, or giving learners and staff nicknames without asking them. So that's one example of microaggressions. Other examples, undermining and dismissing people. In practice, for example, when minority ethnic staff or learners share ideas or offer solutions, and we know that diversity brings creative solutions, they can be dismissed. But when the same ideas are presented by white staff, they're received positively. So these have been shared to us by the staff and students themselves. Another example would be the lack of equality in allocation of tasks and learning opportunities. So what we mean by that is, for example, where Black learners have shared with us that when they are given tasks, they're often tasks carried out by healthcare assistants and they see that white learners are offered learning opportunities to develop their skills. So these are just some examples, and if listeners would like to know more about these behaviours, they can certainly head to the NHS Learning Hub and look at our category, which is titled Inclusive Training Within Practice. We have a series of case stories that listeners can read. It offers reflective and reflexive questions, which is all about your own learning and understanding of these issues.
I mean, some of the examples you've given seem pretty bad. What sort of impact do these experiences have on those individuals who receive them? Do they leave their jobs? How does it affect them? Does it affect their health or anything?
Yeah, absolutely. Most of all, it affects well-being and mental health. It affects confidence. It certainly affects the degree outcomes. So, for example, progression and completion of programs of study. For the workforce, it affects people's confidence in the workplace, their ability to go for opportunities for progression. And yes, certainly people do leave organisations, and we see learners leaving their programmes of study as well. This comes through in the data that we see, but actually the data itself isn't enough to tell us the full story. And this is where we're asking staff and students to share with us their lived experience. So these stories we're telling is really about the reality of the lived experience that we see.
I can see why you really want to do this work. It sounds so important. Mark?
Just listening there to you, Noor, talking about that, I think it's really powerful. Before I come to Antony with a question that I've got, I just wanted to know, Antony, is there anything you wanted to add to what Noor's just said there at all?
I think probably the only thing I would add just quickly is that I think it's to really stress this isn't about a small number of examples. We aren't talking about sort of one-off pockets here or there. It's systemic. This is affecting so many staff across the piece. It's not about small elements we're dealing with. This is about systemic change, and actually that change that's needed because it's in the culture more generally.
Yeah, thanks, Antony. And I can really see, and spending time with you both doing this project, seeing your approach to this and the way you've actually thought about it, and how much consideration you've put into place to try and look at, evaluate and understand what's going on before then embarking on these fantastic learning resources. So really powerful stuff. Tell us a little bit, Antony, about the partners involved in this fantastic work and the kind of collaborative approach that you undertook.
Yeah, so when we sort of thought about the definition phase of the project, we were thinking more about 3 representative Southwest integrated care systems, and we're thinking about getting local populations, workforce demographics. But what was really interesting very quickly, especially as we sort of really started scoping the project, is that so many other areas wanted to come involved. And I did have to write this down because I thought I'll lose track of it otherwise. We talked about Bristol and Western, North Somerset and South Gloucestershire, Dorset, Devon, Somerset, Cornwall, Bath, Swindon, Wiltshire, and Sarona Care and Health. And it was really about this sort of multi-system approach. And as part of that, it wasn't just 1 or 2 individuals from groups. It was learning and development leads. It was EDI leads. It was practice education leads. It was trying to bring together a very big group. And as part of that, an absolutely essential part is also working with other HEIs and further education colleges, because especially focusing on the student element, it was working in that sort of space. So again, we talk about universities such as Plymouth, Bournemouth, Oxford Brookes, and further education colleges, City of Bristol, Western, City College Plymouth and Bridgewater and Taunton. I haven't sort of listed everyone literally, but there's a huge number of people involved. And I think equated about 100 collaborators from 16 organisations. And that's before we sort of even touch into some of the feedback panels as well. So it's a huge piece to make this meaningful and authentic, which you can't do in very small isolated pockets. It's got to be bringing people together in a meaningful way.
Wow, I'm glad you wrote it down because I've lost count already. There are so many people. That must have taken quite some managing from you two. Noor, coming back to you, are there any particular areas that you might want our listeners to particularly note, that you want to highlight about this project?
Yes, thank you. I think it's really important to help your listeners understand what's involved, what's included in these resources, to understand how impactful they are. So our range of collaborators and learning designers have all agreed on some golden threads and key themes that run across all of our resources, ensuring that there's consistency across, because we want to avoid that siloed training and learning packages, and this is connected. Our golden threads are embedding critical race theory and avoiding the deficit model. So that's across the board. Our key themes, which are embedded in all of our resources, is racial literacy, power dynamics, and reflective and reflexive practice to enable people to join that journey. Now, all of these resources will be published on NHS Learning Hub. It is open source. We want to make it as accessible as possible. And it is available to all healthcare organisations and education providers. So we've made it as open as possible. In terms of what these tools are then, they will be in the form of self-led tools, so self-access, e-learning packages that organisations can embed within their organisations, and actually we would encourage system working and integrated care boards looking at embedding e-learning across the system with their partners, and also trainer-led programmes, because we feel that some of this work requires guidance to really dismantle some of the behaviours that we see. So hopefully that will be useful for listeners to understand what's involved within those learning packages.
And looking at the packages, clearly they've been designed for health and care systems, absolutely. But having had a good look at them, quite a lot of them I could imagine being actually transferable to other sectors and employers in general. I mean, do either of you have any thoughts about that? Could they be generically applied to other businesses and things?
Yes, absolutely. The approach we took is that we made the learning resources appropriate for particularly nursing, midwifery and allied health professionals, because that's where we saw the highest level of disparities in the data. However, we've made it appropriate by using examples within the learning resources. It's quite possible to change the examples for different sectors. And so these resources are really appropriate across the board for many sectors. And actually some resources, such as the implicit bias e-learning package, would be appropriate for any sector anyway, as it is.
Right, they're really adaptable, particularly the legal ones as well, I thought.
Yeah, so just to add, we without needing to go into too much detail, we're having some conversations with education colleagues about teacher training and being in that professional space. Again, just as Noor says, there are so many transferable elements to it. So that's just one area about teacher training. And obviously we do that through university, but then they're out in placement in schools and colleges more broadly. So we're having initial conversations in that space.
So a big project like this inevitably would have had a few challenges. What perhaps might have been some of the more prominent challenges that you guys faced doing this work?
I was reflecting on this, and I think, you know, what most people would think straight away is that, the biggest challenge relates to, people not accepting at all there's any racism or discrimination. And certainly that is there. But I think, especially from my experience, working for a long time in the awarding gaps and improving those areas for students, actually it's not necessarily the response that there's no racism and discrimination. It's more that accepting, yes it is, at first of all, absolutely, but it's not me. It's not in my areas. Yes, it absolutely happens. I accept that, but it's not in my university. It's not in my hospital. It's not in my school. So it's very much that, yes, it's there, but I'm not responsible. It's not connected to me. In fact, I'm sure it's not happening anywhere near me. And it's that really hard thing to tackle. And it's still disappointing. We still have to keep pushing. And after decades of evidence, and it is obvious, but after decades of evidence, decades of hopefully trying to push for progress, is you still get it's there, which is progress in a way, but it's not me. But it is. This is the point. It is everywhere. It's in all the spaces. And the hardest journey people go on is having to accept that it may not be conscious for many, for most in many ways, but it's there. You are actually doing things constantly which are undermining staff and students. And it's a hard journey to go on. But that's kind of probably the most challenging area for me.
I guess most of us don't think of ourselves as being racist or exhibiting discriminatory behaviour because we don't think we fit that stereotype image of what we think a racist is. So I can see your point that it can be unconscious, subconsciously demonstrated in the things that we do, such as the microaggressions that Noor was talking about.
Absolutely. I guess, Noor, from your perspective, what do you think are those biggest challenges? Anthony's kind of given us some really tangible examples there. What for you would you say was the biggest challenges?
Yeah, I think for me, the biggest challenge was right at the beginning of the project, where we tried to socialise the project design and approach across the Southwest. And so the approach was a multi-system, multi-professional collaborative effort to address those common challenges that we share, is a new and innovative way of addressing racism and discrimination. And it requires stakeholders, colleagues, to think differently. So asking colleagues to shift focus from the local to the collaborative. Now, that's a challenge in that, yes, people are on board and wanting to learn new ways of working. But in that collaboration, it took about 2 to 3 months of engagement and guiding and supporting stakeholders for them to really understand the approach. And we absolutely need to give colleagues time to process this and understand the information. But with that, the challenge we have is that we are on a tight timescale, we're on a roadmap, and actually once colleagues understood the approach and once they understood that this is cost effective, this is sustainable, it's scalable, they were very much on board, but we needed to give them that time to get to that point. So the challenge is that we did work very quickly over a short period of time, and colleagues then were ready to get on board, ready to join collaboration, very close to our sort of phase of collaboration. So managing the volume of people was a challenge. At the beginning, we were sort of thinking, will we have enough interest? And actually, as we started collaboration, we had a lot of interest. So we had to manage the numbers, but we tried to include as many colleagues as possible in the process.
Thanks, Noor. That's really helpful. And I couldn't help but think in there about either you're on board with this or you become just a bystander and you just let the systems, the culture, basically just glide over you. And I think that makes you someone who possibly doesn't take this work seriously or doesn't take the impact of the work seriously. So there's something for me about absolutely being on board with this work and being not just, dare I say, an activist, but also an advocate for change as well. I'm going to put this question out to both of you now. I mean, I'm sure you've both got your views on this. What surprised you the most from what you've learned or witnessed during the project? What surprised you?
I think, actually, funny enough, it ties in with what you were just saying, Noor. I think it's just the sheer passion and enthusiasm of the groups. You know, it was really inspiring, and that's hard to capture in like just me saying it. But it was amazing. It was really inspiring about how connected people were and how they wanted to be involved and actually what they wanted to do an impact. And that's the thing that I think was really driving for the project, which was fantastic. And it wasn't surprised as such, but it was just amazing to see.
Thank you. What about you, Noor?
Yeah, I would just expand on Antony's points there, that, at the start of the 4-month collaboration phase, I was very mindful that our 100 collaborators may drop off or lose interest over time, as often happens with collaboration. But I really was pleased that, month after month, colleagues came back, kept joining sessions, and they had real connections with our learning designers and group members. They had this rare opportunity to have this safe space and to share the challenges. So I was really pleased that they were on board and they were really invested and committed in this process. And I think we have to recognise that our learning designers were fantastic in leading those 7 collaboration groups. And I think it's a sign that some of the collaborators even tried to join sessions after they'd concluded. So others asked for more sessions. So there is definitely this interest to connect with others on these issues, to collaborate regionally, and to have the opportunity to share experience and find solutions. And I think that whilst we have regional networks in academia or in practice education with strategic leads, these are operational colleagues who are on the ground supporting learners, working with international colleagues that really want to connect with others. So this network, this collaboration was a rare opportunity. So that was fantastic.
Oh, that's brilliant.
Well, that sounds good. Of course, all the work that we do within the ICA is all about making a difference to people. So what kind of impact do you expect this project to have?
So I think I can probably split this into 3. Essentially, just what Noor was talking about. I think the short term, interesting, is quite often one of the big benefits about projects like this, and many times why they're designed this way, is actually just that the conversations, that collaboration, that initial connection has a large impact. But actually, what the project is, it's the other areas, it's the medium and long term. So the medium is actually the use of the resources, that it started to be used in training, it started to be used extensively, it started to use more expansively. And the long term is actually, it's about that culture change. It is that sort of 3-stage thing. And I think that the short term is great and everyone loves the collaboration, everyone loves getting together, everyone loves those connections. But actually the big impact that really underdrives this is actually how do you use the resources then being used, and actually that culture change piece which is built in as well.
That'll be the real proof of the pudding away too.
Yeah.
So what are the future plans then?
Yeah, well, once all the learning resources are published at the end of November, we move on to our next phase. We will be supporting healthcare organisations, further education colleges, as well as higher education institutions to really embed these resources. And we'll support colleagues to understand how these resources actually deliver against existing priorities, strategies and policies. So these are complementary, and we'll be supporting colleagues to understand how they deliver against those. We'll also be spreading and scaling these resources through promotion. We'll be using the regional networks as well as national networks, and certainly the integrated care systems and integrated care boards have a part to play. And as Antony mentioned, very important, we will be evaluating impact. We'll be carrying out benefits realisation processes, and we will certainly be putting in measures to ensure legacy of these resources as well.
I think that sounds fantastic, Noor. Concrete examples of where impact will be felt and how we evaluate that. So I'm sure in your lifetimes, I certainly have, you've seen many projects come and go, right? What makes this project different from your own kind of thought perspective here?
I think from my perspective is, and this is going to be a slightly odd way of putting it, but it's not a passion project that makes lots of noise and then vanishes, which happens a lot in projects. The whole design of this, it's been collaborative. Crucially, it's tapped into common shared challenges. It's avoided duplication. We bring in other things that are happening to really connect it together. We're very much looking at that holistic, complementary and approach. And I think crucially, it's about the sustainable and scalable. Because again, it's not about let's make a lot of noise on this. That's great as it is. It's about how do we actually make that sustained difference in the future? Because all projects do have a beginning, middle, end, and we have to accept that. Project work is great, it has a focus, but actually the thing about this project is that it's about what is the life beyond that. Where does that go? How do you make that culture change using the project as that vehicle?
So I think we're probably nearing the end, aren't we? We could carry on talking about this for ages, but I know we can't. Before we wrap up, is there anything that either of you want to share with us before we finish?
Just that reminder that Noor said earlier, that obviously the resources are available on the NHS Learning Hub. They're available now, but we're going to be aiming to have them all up by the end of November, early December. So please do keep engaging.
Great. So, thank you so much, Noor and Antony, for joining us today and sharing your insights around this really, really vital project. I guess what stands out for me is that this is so practical. Often we hear about a kind of institutional racism. We hear some of these terrible experiences that people have had. But many people like me often feel a bit powerless about, what can we actually do apart from feel really bad about it? What you've done through the collaboration and the work you've done, you created really, really practical resources to allow companies, individuals to do something about it. Really stands out. So it's been such a pleasure to have you both on the show.
Brilliant. Thank you.
Thank you so much. It's been great to share our work with you. So thanks.
And thank you to our listeners for tuning in, as always. Don't forget to subscribe to Let's Talk Health and Care for more episodes in the latest of health and care innovation. And because we do like a little bit of future gazing, Mark, perhaps you can give us a little sneak preview of what the next episode is going to be all about.
Oh, absolutely, Peter. Thank you. So in the third episode of this particular podcast series, we're going to be joined by Associate Professor Alexandros Stratakos, who is an associate professor, and he works in, how would I describe his work? It's just fantastic. He works in the kind of food systems, agri-food space. He's got a real passion for innovation, and he's based in applied sciences here, but has a real linkage across to solving real-world challenges. And one of those areas that Alex is working on happens to be around 3D printed soluble food for those patients who can't swallow, or dysphagia is the actual medical term used. So spending a bit of time with him, hopefully, and exploring how he's approaching this work and for which population group, I think is going to be another really interesting conversation just like this one today.
Wow, 3D printing of food. I can't say I've ever heard of that. So I'm sure our listeners will know all about that, but I'm really looking forward to hearing about that. So that wraps it up. So until next time, do stay healthy and take care.
And it's a goodbye from me, Mark Griffiths.
And goodbye from me, Peter Brindle. Goodbye.